pulmonary V1. شوف V1 is closer to the right ventricle. So anything going left will go towards V1 فهيكون positive. وبعدين inferior leads هيكونوا في الجهة هذه. Going away from the inferior leads هيكون negative. Going towards هيكون positive. فالنيجاتيف هيكون posterior wall. وبعدين concordance V1 to V6 لو كله positive معناته it's likely basal. لو كله negative so the only thing اللي بتشبه الوايت كيورس كومبلكس negative في V1 to V6 كله negative. هذه VT لا محالة. صح دكتور؟ لا محالة. ما تقولش
كان الابليشن ما نجحش.
تربيشن الفي او تي في تي ميديكال ثيرابي ما تحطش اي سي دي لان ستراكشر نورمال هارت الاف از نورمال الا لو مثلا المريض they collapsed ولا صار ايه لكن that's not most likely it's not going to happen.
يعني الريسك we have to move on. It's good to generate discussion but we have to move on.
اعطينا بس دكتور لا 10 مرات.
ان الرايت مورفولوجي والليفت يعني ان جنرال لكن you have to تشيك كثر الاكسس احيانا
اكيد
تخدع.
Yeah, this is a general rule طبعا. Yeah, it's a general rule. يعني كل شيء general rule. شكرا.
Thank you very much, Dr. Yusuf. Now it's a pleasure also to introduce زميل الدراسة Dr. Adel Dyub, cardiothoracic surgeon in McMaster University in Hamilton, Canada. We thought we'll spice it up today, so we'll get the surgeon involved. So he's going to talk to us about management of AFib. I don't know what he's doing with AFib patient personally, but I'm going to take the appendage during cardiac surgery.
السلام عليكم صباح الخير. يوسف قبل ما نبدأ you have to exclude me from the audience. I don't think I understand anything what you're saying. Just حطتوني زي القطش في الزفة يعني. السلام عليكم جميعا. First of all, I'd like to thank you guys for inviting me for this prestigious session. I think I don't know if it's fair to lump me with these smart people, but I will try to do my best to rise to the challenge. My talk today is going to be on a very important topic. I think, in my opinion, at least in people that we operate on and in the number of people we see these days with atrial fibrillation. It is about how we should be managing people who are coming for cardiac surgery and they have history of atrial fibrillation, and whether they're coming for CABG or AVR or mitral or any kind of cardiac procedure, as long as you are opening their chest. So, slides. Should I go with the? Okay, I'll go manually. I think it doesn't work. Oh, okay. No disclosure. It's working now. It's working. So nothing to disclose. I'll go over with the outline of the presentation. Just to go briefly, what's May's procedure and why we do it and how we do it. We'll go over whether we should do biatrial or left-sided only. We'll go touch upon a bit of the evidence and guidelines, if you will believe them, and predictor of failure. And I'll touch very quickly 1 or 2 slides on the management of left atrial appendage, which I hope we can convince you that we have a strong evidence in that field, and also some take-home messages. So the question we're asking ourselves is, in patients who are undergoing cardiac surgery with the pre-op atrial fibrillation, should they undergo surgical ablation, and should we address AFib as a disease entity? Is it worth the effort? And I hope in the next few slides or during my talk, I'll convince you at the end that I think people, when they come with AFib should not be left alone. Why we are concerned? I think overall, if you look at the atrial fibrillation burden, it is a very common disease. Dr. Amirvat, I'm not sure. If you look at Libya here, I'm not sure if it's true or not, the prevalence of AFib in the population is about 40 to 200, depending on the region where you live, per 100,000. So we're expecting people who are coming for cardiac surgery, a lot of them will have AFib prior to coming to surgery. So Egypt looks like you are red, so it's about 169 to 194 people per 100,000. Libya is green, it's always green, so I don't know how valid that data. Okay. So that is actually that's a lot of burden. So the reason why we need to address it, it is because up to 50% of our patient comes for cardiac surgery. They have pre-existing AFib, more so with patients with valvular disease, namely mitral valve surgery. And it is associated with almost twofold increase of mortality and 3 to 5-fold risk of stroke. And we know them, you do bypass, you do valve, and some of them will not be as happy as clinically because they're still feeling tired, they're still not as you expect them, and you wonder why they're not doing very well. So poor quality of life, increased risk of heart failure, higher risk of readmission. You send them home, you think you did a good CABG, a total arterial vascularization, they're back to emerge with a heart rate of 180. And that ultimately leads to higher cost of caring for those patients, especially those who practice in North America. They know how much just AFib costs the health system. Hopefully the aim of treating it is to try to restore patient to sinus rhythm with its associated benefits with hemodynamics, and hopefully we try to see if we can avoid in people with no other risk factor to be on anticoagulation, to try to avoid being on those anticoagulation, although this is something that I am not aiming to achieve because we know a lot of AFib patients have other reasons why they have to be on anticoagulation, especially with child VAS score that we know. And hopefully we try to reduce the need for antiarrhythmics, as we all know that antiarrhythmics are not the most benign drugs, especially for long-term management. So if you look at the prevalence or incidence and how common by procedure, it seems to be the CABG. If you look at the CABG is about 20% of patients here. AVR, about 20-30% of them will have AFib. And if we look at the mitral valve surgery, seems to be up to 60% in mitral valve surgery patient will have AFib prior. So should we ignore all these patients coming with AFib and just treat them medically? Let's see how the penetration and adoption of atrial fibrillation management during cardiac surgery, this is probably mostly applicable to US. There's actually, if you look, what happened here? Okay. If you look at by 2022, only 30% of people with CABG, their AFib get addressed during surgery. That's the bottom here, okay? 72% of patients with mitral valve has their AFib addressed, which seems to be, especially with the updated guidelines in 2016, there was a bit of uptake and increasing adoption of surgical ablation plus or minus left atrial appendage management, because people are always concerned about risk of stroke and trying to give the patient the best outcome, because there's gradually increasing evidence that if you occlude the appendage, if you do the AFib, at least you reduce the risk of stroke and systemic arterial embolism. So as you can see here, there is a slight increase, but still significant number of people, their AFib is not addressed. So what is Cox-Maze procedure? And this is the godfather of cardiac surgery in AFib. This is a surgeon from US who started in the 80s, started developing the Cox-Maze procedure. And for some of you probably don't know, but it has started into different phases and went to several iterations of his procedure, from Maze 1 to Maze 2 to Maze 3. And for James Cox. This is Cox. Okay, so I was one of the course in ablation, because I have some passion with ablation, so I tend to attend a few courses here and there once in a while, and he was a presenter there. So that was 2017. He started with a cut and sew. He understood the mechanism of AFib more than myself and others. He decided to create lesion blocks. But in those days, in the 80s, there was no energy sources. There's no other way of doing it except slicing the heart and cutting and sewing it back to develop scars. So very tedious operation, long operation. If you guys talking about invasiveness of surgery, this guy opened the heart, opened the chest, and slice it and cut it into. So every lesion that we now create to create any lesion block, he was doing it with knife, and he put it back. So, but he claimed a very high success rate. And over the years, technology companies figure out that this happen all the time. Alfieri stitch puts a stitch, developed mitral clip by the companies, and cardiology claims a success. We do Cox procedure, radiofrequency and cryoablation comes, and company comes to the cardiologist and say, can you do it endocardially? And that's what happened. So this is, he claimed a lot of credit for the advance in AFib ablation management, especially for the surgical society. So what he actually aimed for this procedure is to interrupt the micro and macro reentrant drivers for AFib, which we all know they predominantly present in the left atrium, and some of them will have also some triggers in the right atrium, SVC, IVC. So predominantly the problem is the back wall of the left atrium, as you probably know more than myself. This is the final product of May's procedure, which been modified over the years, trying to simplify it. The reason why AFib management during surgery was kind of every surgeon say, no, I'm not doing it, I'm not doing it. If you want me to do it like James Cox, forget it. I'm going to be doing 1 case a day. So people looked waited until the lesion set has been simplified. And by doing a lesion that takes you 1 minute to clamp across certain part of the heart, and being able to replicate this procedure in 20 minutes, half an hour, people say, okay, now it's safe, I can do it. So the adoption has become more and more. But especially still significant number of surgeons does not want to even do it, because it requires a little bit of more digging and that is one of the problems, is now people, when you talk about reporting your outcome with surgical ablation, everybody start developing his own. Now he has a toy that he can play with, and now everybody wants to modify the lesion set. The lesion sets that were described initially, which achieved higher success rate, ask you to do 1, 2, 3, 4, 5 lesions. I'll go back to the first slide. You have to create the box around the pulmonary veins. You really have to isolate the back wall around the pulmonary veins. You have to amputate the appendage, connect the base of the appendage to the box around the pulmonary veins. You have to create the lesion set on the SVC, IVC, the isthmus to the tricuspid, and you guys don't like this lesion because it creates the flutter and it's very hard to treat. I'm not going to go there. So basically, now people start doing their own versions to try to simplify it. Some will just go around pulmonary veins. Some will forget about the appendage. And everybody calls it Maze. Yes, from the billing perspective, if you do any version of those, any clamp you place it anywhere, you can get paid the same. But your patient will not benefit the most from the procedure. And I think if you start reporting your outcome, you will look bad because you have not followed the guidelines. So what are the energy sources that we use? There's several energy sources that have been described: microwave, ultrasound, this. But I think what's standing out now is the cryoablation and the radiofrequency bipolar clamps that we use. Now we come to the decision making. I think decision making, when you want to address his AFib during surgery, you have to look at several factors. First, what is the AFib weight? Like, what is the factor that could make you successful and not successful? Basically, if you are having somebody with atrium of 7 or 8 centimeter, forget about it, because you're not going to succeed. So I think duration, the type of AFib you're dealing with, also surgical factor. If you are in a center where you do only 200 cardiac surgery a year and you do 3 or 4 ablation, then you're not going to get good at it. So surgical expertise, and there should be a 1 or 2 somebody who's interested in doing this with high volume, and the impact on quality of life and symptoms. So if you have somebody who's 84 years old with AFib and he's coming for coronary bypass, do you really want to convert this operation to much more very friable tissue? You want to dig into the pulmonary veins, you want to clamp, you want to close the appendage. I think sometimes you have to individualize and tailor the procedure according to the patient need. If somebody is 50, you definitely probably want to push and try to do it. And this paper has been also, this concept has been confirmed with this. This is a surgeon from Virginia. He's very passionate about AFib, and he showed that the more comorbid the patient, the less likely the surgeon. So the surgeon experience is very important in performing AFib decision when it comes to AFib decision. So if you look at the comorbidity score on the bottom here, so the higher the comorbidity of the patient, the surgeon will more likely will say, I'm not doing it. The same even in the experienced surgeon. As the comorbidity goes higher, the surgeon, if you start with a comorbidity with nothing, most patients will ablate everybody. Even the experienced surgeon, up to 60% of the time, they might not say, because the patient is fragile, renal failure, I want to keep it short and sweet and quick. I'm not thinking about 10 years outcome, I'm thinking about the year outcome. So switch gears to whether we should do right or left. So literature actually in this field is very divided. I can show you 3 meta-analyses saying this is better than this. Another meta-analysis say, well, this is actually the same. So this meta-analysis showed that actually the left, if you do left or right, they're the same. I think in concept, because we know atrial fibrillation could be triggered from the right side, from the SVC, IVC, it makes sense that you should address it. And that's one of the reasons when I go to meetings, I think the world is moving toward heart team approach in every aspect of patient care. So for me, when I go to address or do the ablation, I'm actually very blind. I don't know anything. I just go there. I know from the history, 90% of the triggers are in the back wall of the left atrium. So I'm hoping that if I isolate the posterior wall of the left atrium, I'll be successful. But again, I have no idea if there's a trigger once in a while in the SVC or the appendage or some ganglion, right? So I don't know it. But I think this is another area that we try to convince our AP colleagues. So anyway, so this is saying the same. This other one says, no, they're actually, biatrial is better. So when it comes to the type of procedure, this is a very large registry from Poland, looked at thousands, about 12,000 patients who underwent mitral valve surgery, and they have a propensity match patients study between the one who had surgery versus no, and showed that the adjusted hazard ratio after a propensity match is actually in favor of doing the ablation. So they recommend that you should do ablation. And oops, I'm going the other direction. Also, this study looked at 5 years to 6 years outcome, shows that ablation in mitral valve surgery is durable, with 74% of patients are in sinus rhythm and 64% are off antiarrhythmics. Again, same principle for people with CABG. This is a large data from the STS, looked at patients with CABG and divide them into paroxysmal or persistent. And again, if you look at them, the survival and freedom from stroke was in favor of the group that has their AFib addressed during surgery. I will just go over to, and that led to the guidelines to recommend ablation in mitral and non-mitral surgery as a class 1, and also occluding the appendage as also class 1 for prevention of stroke and systemic embolism. The ECC guidelines do not agree. That's why I think when you read the guidelines, you have to be very careful. We have 2 very good guidelines, one say class 1 and one say class 2, depending on how you interpret the evidence. Quickly, predictor of ablation failure, size of the left atrium, duration of AFib and old age. Very quickly, 30 seconds on the appendage. This is a study that was run by one of my colleagues in McMaster. It is the LEOS 3 trial. Dr. Rich Whitlock, he was actually my classmate, ran a study that is, I think, randomized over 4,700 patients to occlusion versus no occlusion in patients who had a history of AFib. And came to a very good conclusion. Actually, the group that monitoring the study asked him to stop the study at 3 years, 0.4, I think median follow-up was 3.4, because there was a very positive finding suggesting a 33% protection from stroke and systemic embolism by 3.4. So hazard ratio of 0.67 with p-value of 0.001. And now it is telling the ECC guidelines to recommend a AFib patient to have their appendage occluded during surgery. And even now there's an attempt to even do occlusion of the appendage in patients with no history of AFib, because there's some meta-analysis suggesting that even if people come to you with cardiac surgery without history of AFib, if you occlude their appendage, their stroke risk is lower. And same colleague who's very passionate about AFib, now he is actually designing the LEAPS trial, which is left atrial appendage occlusion as a prophylaxis for stroke in patients with no AFib. He's now looking at sample size of 6,500 patients in 250 sites across the world in patients with cardiac surgery with high risk of stroke or AFib risk undergoing cardiac surgery. He's going to follow them for 5 years. Cardiac surgery likes to follow patients for longer they have to wait until they prove the outcome. Unlike cardiology and intervention, they're happy when they see 3 months and 6 months outcome, and they start publishing and changing guidelines. The primary outcome is stroke and systemic embolism. Take-home message very quickly. I think Cox-Maze procedure is safe and effective. Surgeons should base the decision to perform ablation based on the physiology and the benefit of the patient, not on the type of the procedure, that is, whether it's a CABG or valve. I think, in my opinion, biatrial Cox-Maze is superior than left, especially if you're dealing with non-paroxysmal, and especially in a little bit of persistent or chronic. The other one is, I think, still, despite the uptake that we've seen recently, AFib, addressing the AFib during surgery is still underutilized. Radiofrequency and cryo remain the two main energy sources, and I think a left atrial appendage should be recommended in any patient with AFib to reduce the risk of stroke and systemic embolism. But very carefully interpret this. Does not mean that you stop your NOAC and your anticoagulation, because I think occluding the appendage is actually additive, synergistic to the ongoing antiarrhythmic, especially if your child VAS score more than 2. Thank you.
Thank you, Adel, for a very nice presentation. I know you expect a few questions from me at least, so I'm going to start with you. So the advantage of what we do percutaneously is we have endpoints. We do lesions, we look at endpoint, electrical endpoint. The disadvantage of surgery is you just do anatomical lesion, right? So this is always. However, I do agree with you, if patient going for cardiac surgery and they have AFib, we always recommend surgical AFib ablation. I have a few technical questions. We always do procedure on full anticoagulation, whether we cardiovert, we do AFib ablation or not. You guys stop anticoagulations for a few days. The patient in AFib, they go for surgical ablation.
We bridge them.
With heparin?
We bridge them with sub-Q heparin, with the fragment or something, so until the night before. So they are bridged. It's like with mechanical valve.
Oh, that's good, because in our institute, I don't think they do that, so that's good. Now, one of the common things I've seen is when it comes to atrial slip or appendage closure, I don't know if Dr. Murphy will agree with me, is when we do Watchman, for example, we always do a TE or CT to make sure it's occluded. I had an incident of a recent case where the appendage was clipped, but we had to do a TE for a different purpose and cardiovert the patient, and we found there is a pouch. So it's not unusual sometimes you have a pouch. Mm-hmm. Is it your practice you check for atrial appendage closure?
According to this, especially when I'm part of the LEAPS trial, so been randomizing, our center randomized almost 300 so far, so mandatory to have an intra-op TE to check before and after. If there is a stump size, if there's a flow, you have to document if there's a flow. So basically for me, if I do a clip, I have to check after coming off bypass if there is any residual significant stump, and if it is, you have to document it. I don't think they accept anything more than 0.7 centimeter, and you have to either apply another clip or you suture or something. So you should not be leaving, and that's, I agree with you, even the previous study have reported, especially for those who either put a ligature across or staplers, people sometimes tend to, because it's a very vulnerable area, you don't want to be closing too close to the base, you might end up with some damage to the circumflex. And so, but I think people develop more and more techniques, and I think the clip, especially with the new one with the Flex V, is actually a very good clip, especially when you do it in a decompressed heart. You should be able to mobilize the base, and you should be able to capture all the loops.
So I've got a question for Dr. Murphy, then I'll open the floor to my colleague. So Dr. Murphy, we commonly see these patients after their left atrial appendage closed. They come for cardioversion. They're not anticoagulated. Do you cardiovert patient with atrial appendage surgically removed or clipped without anticoagulation?
I don't have experience with this. But if I get a patient with a surgeon closing it surgically and he is on anticoagulation, I don't go with TE. Most of my patients, the surgeons do the mitral and the appendage closure surgically. We don't have this slipping, we have the surgical. So I'm sure it is closed very well. But they come also on anticoagulation. So if I cardivert them, I will go without TE to make sure. Left atrial watchman, we don't have it so much in Egypt. It's only few cases. So I haven't seen patients with the watchman closure and they have to be cardioverted. What I want to add is that not all surgeons do AF ablation with mitral valve surgery. And most of them maybe they do the appendage closure, لكن مش كلهم. If I want an AFib patient who is going to undergo mitral, I have to send him مثلا جمال سامي ولا صابر. Some few surgeons who will do this. When they started, we started with the Cobra, and I have to go with him to tell him where to go and to do, not exactly maze, but the lines like the one we do in endocardial. And then when we don't have the Cobra, then we have to use the cautery, the Bovi, the Gamal Semi. And then I have to go with him with my RF catheter. I give him the 8 millimeter catheter, and I have to go the ablator to make it open, like manual unipolar, because the patient is very cold, so the temperature control will not work. So we cheat the machine and make it work manual unipolar. So no temperature. So yes, this is the Egyptian way. So we did. I went to the surgeon with open heart, my surgeon, and I was fascinated by their work, of course, because I love surgery. And I was shocked that we go to the left atrium with our catheter moving and moving in this very small space. I said إيه ده؟ إحنا جنان ولا إيه؟ لما بتشوف الجراحة وتشوف القلب مفتوح والفينز كده، أنا بقف على كرسيين عشان أبص مع الجراح وهو داخل بالقسطرة بتاعتي أو بالكوبرا عشان يعمل اللاينز دي. إحنا بنعمل إيه؟ إحنا بنعمل اللاينز دي بالكاتن سو دي خلاص. كاتن سو دي خلاص. فالسيرجيكال ابليشن اللي اتعمل في مصر هم عدد قليل من الحالات، انا وجمال سامي ومحمد رفيقي وهكذا، حاجات فيري سبوراديك، ولا هي جراحين معلش مكبرين دماغهم يعني ايه كمان لسه هعمل لك ايه في ابليشن، فبضطر ان انا اروح للجراح اللي مقتنع بذلك. مفيش هم 2 3 في مصر. فالجراحه نفسها اللي هي بيمسك الكوبرا دي اسهل اندوكارديال او ابيكارديال لو هو مش هيفتح، لو هو جاي كابج والعيان هيعمله. طبعا ما عندناش بقى statistics وحاجات من اللي انتوا بتعملوها دي في بلاد بره، فاحنا يا دوبك كده ايه بيرسونال اكسبيرينس خالص.
دكتور ميرفت عفوا انا بس you mentioned something about the surgeon using the cautery. I think a lot of people, as I said, one of the drawback of surgeon is everybody trying. انت عملت ال Egyptian version, whether it's so because of the resources issue. The problem is if you start modifying and tailoring things to your need and to your local resources, the outcome won't be the same. So my recommendation is, because like for example using the clamp, it will ensure the transmurality, and also the more meeting I go to, like I remember when I was in my training, my program director, when he does ablation, he only apply 1 lesion set. When I go to meetings and I come back, most people apply 3 to 4 times. So yes, the machine will peep and tell you this is a transmural lesion. You have to actually, first we have to also dissect and make sure that we actually staying away from the pulmonary veins so that we don't cause pulmonary vein stenosis. So I think it does require some work, but I think I will warn people to start cheating and doing, cautery. Bipolar is better than monobol. If you have the pen and you try to walk, you will miss. You will have some trouble. The other thing is for mitral people is 2 things. You have the luxury of creating the roof, the floor. You have the whole complete box. You have the isthmus lesion to the mitral. You have the connection lesion to the base of the appendage. But one caveat for people who does mitral valve and trying to occlude the appendage from within by suture, these are the ones that will recanalize in the future. Because first of all, people will try to cheat by staying away from the place where the risk of injury to the circumflex, and that will lead you to do a very bad job.
I think we have a couple of questions where we are running out.
Bismillah. Thank you, Dr. Adel, for the interesting session.
أيوة.
Interesting. So, I have a couple of questions. Number one, is there any comparative data regarding the success rate as a cervical ablation combined with catheter ablation? Because this means a lot. Is it worth it to go for surgical, or shall we keep it as a hybrid with our colleague cardiology? Or I think what we are doing, as you mentioned, that sometimes we are doing it blindly, we don't have a mapping of the resources of re-interest. So this is one of the questions. The other question, what about the coronary science when you do surgical? Are you going to do cryo ablation? And you know that it's a little bit some risky regarding the coronary science. The third thing, based on the cost effectiveness, as you mentioned that now new era for left atrial appendage clip combined with the old-fashioned scissor ligation. Is it necessary to go for, as our colleague from Egypt mentioned, that sometimes the resources pushing you to go for ligation rather than the clips, because as you know that I think it costs $300 or $500, if I'm right.
The clip?
Yeah.
The clip is 3,000 to 4,000.
3,000 to 4,000. So it's
The Watchman is 18,000.
Yeah. So this will lead us to another question for the cardiology. I think that the concept of Watchman is different than the left-hander clip, because the clip is the aim of it is making a ischemia for the appendage, which is making it is decreasing the resources of the ablation. But I think the Watchman is just preventing the thrombus inside the appendage, if I'm right. Thank you. I think I say 4 or 5 questions. Yes.
I think if I remember, the first question is about the comparative. I think if you look at most studies, as a surgeon, I think most of us will deal with the chronic type. We don't deal with, very rarely that we have somebody who just started AFib last week or the week before. So most of them are chronic or persistent. So there's actually a growing body of, I think even it's in the guidelines, there are actually a crazy group of actually now trying to tackle a lone AFib, people with no structural heart disease, with no coronary disease, with nothing. But this is not to be done by open sternotomy, or some people would advocate a mini approach, but actually people in Holland, in Germany, and even in the US, they're trying to do a thoracoscopic. So thoracoscopic bilateral, they do thoracoscopic right side lesion, thoracoscopic left side lesion, they open the pericardium and clip the appendage. And to me, that's a very cheap version of addressing the appendage. I think the penetration and adoption of this is still, but I don't think we are in a position yet to do any head-to-head to Watchman or to oral anticoagulation only. But I think there is, every time I go, people telling us there is an era where we're going to have what we call AFib surgeon. It's like we have coronary surgeon, aortic root surgeon. In the future, I think there are almost 4-6 million people in the US that are having AFib. I think if you actually refine and develop your skills, I think it would be a very complementary option for your patient, especially those who has clots. Some people who are resistant to other treatments. There's a lot of failure of ablations. And I think, anyways, I do feel the field is heading toward hybrid, concomitant. We do certain lesion set, they go and touch upon certain lesions, and they can fix the gaps. And I think if both teams can work together, probably the patient will benefit the most.
Adel, thank you very much. I think we are really overrun, and the next session is about to start. It's been a pleasure to have you all.
Salam.
And I think it's time for a well-deserved coffee break.